Hi, and welcome to our customized training from the Robinson Lloyd Resiliency Group. All we want to focus today on specialized care, right? So I recognize that it's not always easy for us to meet every week, for 5 hours to discuss trainings. We thought, well, why not just bring the training to you? You could view it at any time and call or email if you have questions. Today, we're going to address the three things that you asked for help about. We are looking at ADHD, we are looking at ODD, and we're looking at depression. ADHD, attention hyperdeficit disorder, and we are also looking at um, oppositional defiance disorder and depression. Now, we are just going to be focusing on understanding or getting a basic understanding, a working understanding of these disorders and how it could affect a teenager. In our next video, we'd be looking at skills that would be very, very effective and very useful for us to help that teenager to thrive. All right, so let's begin. I'm going to share my screen. I'm going to pull up our slideshow. Okay. So again, welcome to our foster parent development. Understanding and responding to specialized mental health situations, ADHD, ODD, and depression. I need to also share my sound. Okay. All right, so our learning outcomes, we're understanding what ADHD is and how it presents in teens. Of course, we're going to have a discussion. For our discussion part, I'm going to make sure that you have, just some questions for reflection since it's not in person. And I'd love for you to help me by sending just a quick email or I think emails would be best. A quick email about your reflection. Very short, right? Just one sentence would be great. Understanding ODD and how it presents in teens, understanding depression and how it presents in teens. And then we'll be assessing how to adapt our environments to support teens with ADHD, ODD, and depression. We're going to have a case study. We're going to assess how to support emotional well being of teens, as well as some helpful conversations to have with the doctor, as you would be responsible for taking the child to his appointments. Okay, so understanding ADHD. As I know you love videos, we are going to view a video of a lovely young lady who's sharing her experience of living with ADHD.
Hi, my name is Lindsay, and welcome to my life. I have attention deficit hyperactivity disorder, also known as ADHD. You might have heard it before, maybe from your psychology class, your friend, or even online. At some point in your life, I'm sure you've had difficulty sitting still in lecture, paying attention while studying, or being engaged in impulsive behaviors. However, when these behaviors persist over time, they become signs of ADHD, a neurodevelopmental condition. ADHD affects various aspects of my life. Typically, I have trouble focusing and can become easily distracted. This is known as inattentiveness. I also have trouble sitting still for short periods of time, known as hyperactivity. I've been told that I can get impulsive at times. Often, my body acts before my mind, which can lead to unwise decision making, inability to ignore danger, and inability to learn from previous mistakes. But what's really ticking in my head to make me, well, me? ADHD can be explained by physiological and neurochemical mechanisms. How about I show you? Let's look into the brain for a second. At the front exists the prefrontal cortex, which is part of the frontal lobe and contributes to complex behavior, planning, and personality development. Individuals with ADHD, like me, tend to have a smaller right side compared to the left, resulting in small right brain activity. A study showed that 90% of ADHD children also had right cortical lesions. In another study, children with ADHD were also diagnosed with hypoperfusion, known as low blood flow, in the frontal lobe, while there was high blood flow in the occipital and temporal cortices. Now let's delve even deeper on the neurochemical side. Norepinephrine, a stress hormone that activates our fight or flight response, and its precursor dopamine, a chemical that contributes to our pleasure and reward system, are both neurotransmitters and are found in low levels in ADHD patients. Both dopamine and norepinephrine also contribute to maintaining thoughts, alertness, effort, motivation, and increased focus, so it's easy to see why low levels of these two would affect individuals like me. This is my doctor, Dr. Miranda. She can tell you more about some treatments I've done and I'm using now.
Hi, Lindsay. There are two general types of treatments for ADHD that treat different aspects of ADHD: pharmacological and psychosocial treatments.
So, what do each of these treatments address?
Great question. Pharmacological treatments have more of a direct impact on the neurochemistry side of ADHD, as discussed earlier. Medications like amphetamine are stimulants. Stimulants are the most effective treatment for ADHD and have a responsiveness rate of 70 to 80%. What they do is they block reabsorption of dopamine and norepinephrine, so they keep their levels high.
How about psychosocial treatments you mentioned?
So cognitive behavioral therapy, or CBT, is a type of psychosocial treatment that can be done individually or in groups. CBT is designed to promote self-controlled behaviors through self-reflection and control strategies like time management. So an advantage of group therapy is that it allows children the opportunity to improve their behaviors without the use of medication. It is actually the preferred method for children under the age of 7 because before this age you haven't yet fully developed your self-regulation abilities.
Wow! Thank you for making everything clearer in terms of choice of treatments. I personally find CBT helpful for myself, but everyone is different.
Yeah, absolutely, Lindsay. Anytime you or your friends have any questions, always feel free to come to us. We can help you out.
Thanks, Doc. Have a great day.
Okay. So now for our
Hi, my name is Lindsay.
discussion questions. What is ADHD? How does it make life more challenging for someone with ADHD? And how is the brain different for someone with ADHD? Right. So we just, again, just a one line response via email would be awesome because that way I can know that you're engaging with the material and you're doing it at your own pace, at your own time, and I'm still here for you in a very live and direct way. All right. So now we want to get into understanding oppositional defiance disorder, ODD, oppositional defiant disorder. And I think before moving on to, this sort of blurry, even intimidating world of disorders, I want us to stop and think for a while. Think about the relative or the aunt that you had that nobody knew what they were really dealing with. They might have been sad a lot, and somebody said, oh, that person's just always in a mood, right? So we never labeled things, but we saw behaviors that were, a little bit, strange. And we just kind of made it work, right? We worked around the person. We managed, is this person in a bad mood today? Should I talk to them or not? Right? So we, you know, fast forward, we have a world now of labels. And these labels are not meant to scare us. They're not meant to think, oh my gosh, what am I dealing with? Like, this is too much. It's just meant to say, oh, you know what? I just need to learn about this. And when I learn more, I'm able to identify it, see it, and I'm able to cause helpful situations and not harmful situations. Now, please note a lot of these, a lot of what becomes a disorder first starts out in the environment. Now, mind you, we also have something called a genetic predisposition. So somebody might be genetically predisposed to having attention hyperactive disorder, hyperactivity disorder, right? ADHD, attention deficit, sorry. They might have that genetic predisposition. All that means is that their mom or their dad may have also had ADHD. And when those genes split, and entered to form a new person, they may have had the gene. Now, here's a good thing about genes they do not have to turn on. Genes could actually remain relatively dormant. What turns the gene on is our levels of stress occurring in the environment. Now, for children who've been neglected, who've been abused, those genes are switched on in an effort to cope, right? And it becomes a dysfunctional way of coping. So, for example, if for the child who has attention attention hyperactivity disorder ADHD, for a child who's experiencing that and they're hyper, they may be always feeling a sense of, okay, I gotta be on the move. I don't know what's going to happen in my environment. It's very unpredictable. The child who has the inattentive subtype may be getting a lot of comfort from just withdrawing completely and going into their own worlds, right? And so, habits that we train the brain, it's all about training the brain. We train the brain to respond in certain ways. The gene is switched on, and the pathology starts taking root. Now, when we say to ourselves, they're going to grow out of it, it becomes even more serious. Why? Obviously, because they don't have the tools to cope with more and more demands, and life is a constant levels of stress, and being able to adapt and being able to experience stress and adapt and stress and adapt. It's a constant level of stress and adaptation. And if they're unable to have the tools from young to say, oh, it's just ADHD, there are medications that are helpful, there's therapy that's helpful. I just need to find what works well for me, right? And that's, you as a parent, you're going to be able to foster that attitude. This is just a matter of finding what works right for you and ensuring that your day to day life experience is a lot more pleasant. You're able to adapt better and you're able to connect to other people. Okay, so I just wanted to stick that in there, before we get into talking about more disorders. Okay, so I'm just going to take a time check because I do have to stop at about 7:10. So we'll see how much we can do today, and I'll be sure to be making these videos for you. Okay, so let's look at oppositional defiant disorder.
Hello, this is Dr. Grande. Today's question is, what is oppositional defiant disorder? Now, this is a mental health disorder that gets a lot of attention and it's a bit controversial. Part of the reason it's controversial has to do with the subjectivity of the criteria. So, this disorder is characterized by an angry, irritable mood or argumentative, defiant behavior. And actually, there's two groups. There's symptom criteria for angry, irritable, and argumentative, defiant, as well as one symptom criterion under a category called vindictive. 4 symptoms have to appear, and they can be anywhere from these 3 categories. The symptoms have to appear for at least 6 months, and the interactions where the symptoms are observed have to include people that are not siblings. So these symptoms do not apply to sibling interaction. So in the first category, we have angry, irritable mood. Now you'll notice here, as I'm going through the symptom criteria, that the word often is used in 7 of the 8 symptom criteria. So for the first one, for angry, irritable mood, often loses temper. Then we have often is touchy or easily annoyed, and is often angry or resentful. Those are the 3 symptom criteria for angry, irritable mood. Then looking at argumentative, defiant behavior, we have often argues with authority figures, often defies authority figures, often deliberately annoys others. Notice the use of the word deliberately there, so just annoying others would not qualify. It has to be deliberately annoying others. And then often blames others for mistakes or behavior. The last category, the vindictive category, this one is a little easier to quantify. It doesn't involve the word often. There needs to be 2 or more instances of spiteful or vindictive behavior in the last 6 months. Now, when talking about this 6-month rule for oppositional defiant disorder, it's important to keep in mind that for this disorder, there's a distinction made at age 5. So if an individual is under age 5, the symptoms must appear most days in those 6 months. Over 5, at least once a week for 6 months. When looking at the severity specifiers for oppositional defiant disorder, there are 3, mild, moderate, and severe, and they're entirely based on the number of settings where these symptoms are present. So for example, home, school, with peers, at work. 1 setting is mild, 2 settings is moderate, and 3 settings or more is severe. So it's a bit of an unusual way to look at the severity specifier when we compare it to how the severity specifier is used with a number of other disorders in the DSM. One question I get sometimes pertaining to oppositional defiant disorder is, what is its relationship to conduct disorder? Now, generally, we think of conduct disorder as a more severe disturbance than oppositional defiant disorder. Technically, an individual can be diagnosed with both at the same time, although I wouldn't think that would be the expectation. Conduct disorder has certain features that we don't see in oppositional defiant disorder, like aggression, destruction of property, and a pattern of theft or deceit. Also, oppositional defiant disorder has an emotional dysregulation component that we would not see typically in conduct disorder. So the 2 can be differentiated, and as I mentioned, technically someone can have both. It could be comorbid. But usually we think of somebody as having either oppositional defiant disorder, or if the symptoms are more severe, they may qualify for a diagnosis of conduct disorder. So what causes oppositional defiant disorder? Well, there's a bit of controversy around this too. There is one school of thought that says that oppositional defiant disorder is really pathologizing normal behavior. That's one school of thought. Another school of thought is that there's a genetic component, although this is really unclear. We don't really know how genetics play a part in the development of this disorder. There is also possibly a temperamental component to the development of oppositional defiant disorder, an etiological component, and this involves emotional reactivity and poor frustration tolerance. So an individual that exhibits one or both of those would be at a higher risk for oppositional defiant disorder. In terms of parenting, and this is probably the more controversial area in terms of the etiology of oppositional defiant disorder, there have been studies that show that harsh, inconsistent, and neglectful parenting does seem to be etiological to oppositional defiant disorder. Certainly, we know they are risk factors, and we believe they also may be causal. They may be etiological. Now, again, with mental health disorders, including oppositional defiant disorder, there are a lot of potential risk factors and causes that we don't know about. We can't fully explain how these disorders develop. The best evidence right now suggests that the genetic component could be there, temperament could be a part of it, and the behavior of parents could be a part of it. I hope you found this description of oppositional defiant disorder to be interesting. Thanks for watching.
Okay. Okay, so we're going to stop with this one. We're just going to look at the
Hello, this is Dr.
review
Grande. Today's question.
questions. I'm trying to have to click out. Okay. And so, when we're looking at this, before we get into our discussion, we're looking at something called biopsychosocial factors, right? So we're looking at parenting and family factors, parenting behavior. And so when you're dealing with children who are from foster agencies, foster homes, it's a lot of emphasis on empathy and trying to understand where that child is coming from and what it must have been like, right? So, parent child attachment styles. Typically, we're looking at avoidant attachments or neglectful attachments. We have peer relationships, peer rejections, right? So the child isn't fitting in, they're not fitting in or able to build or maintain relationships. And the thing that affects relationship building or bonding has to do with the relationships of origin, the relationships that we have with our mothers, with our fathers. And once those relationships were not secure, were not encouraging, didn't help to foster us or really strengthen us as people, we struggle for a bit, of course, until we learn how to love ourselves and be good enough parents to ourselves. DVNC training, child developmental processes, callous and emotional traits, right? Emotional regulation, executive functioning and language, social cognition, predisposing factors, trauma, raised in an orphanage, precipitating factors, recently punched by a student. So that precipitating just means it came before the incident, right? Recently moved, recent death in family. So some things there, sort of like the child isn't dealing with and it's lurking in the back of their minds and they're, taking actions based on these things. Perpetuating factors, recurring social, family, school conflicts, right? So it's just perpetually always in trouble, always going to the principal, always getting suspended for something. Okay. So it's 7:01. I'm going to keep going for our discussion. I'm going to stop here. I think this would be a good place for us to stop. What is oppositional defiant disorder? What causes ODD? And how could it affect the child's life? Right? So just really, really simple reflections. Again, kindly send me just a one sentence response. It doesn't have to be from any encyclopedia or anything, just your understanding would be good enough. Okay, guys, I look forward to our next video. Feel free to leave your comments, send me your reflections. I enjoy working with you and then I enjoy being a resource for you. Until next time, I am Tonia Robinson Lloyd from the Robinson Lloyd Resiliency Group, where we offer customized solutions. We provide data and essential ways of coping with everyday challenges that that has to do with mental health. Bye for now.